Good morning, everybody, or good afternoon, depending on where you are, and welcome to today's interactive webinar, Community of Practice. I am so excited. We're talking today about trauma, mental health, and resiliency with Jeffrey Cartwright. We are so lucky to have him. He's a really amazing sought-after speaker, and we'll also have him in May, June, and July for a couple of workshops, which I'm really excited about as well. In case you don't know me, my name is Victoria Granger. And I am the founder and CEO of Wellness Works Canada, which is your nonprofit workplace health and performance association. So we're actually the only association in Canada to support people who are working in this industry. And we also support organizations in that role as well. And our aim is, and what we are really kind of focusing on, is really bridging the gap between culture, workplace wellness, and employee well-being, occupational health and safety, and performance and productivity. So we also have the only accreditation available in Canada for workplace health and practitioners as well. And so just to mention that all of our webinars are made possible by our partners and our members. And so if you aren't a member yet, I encourage you to check out our website to look at some of the membership options, both for individual workplace health practitioners and leaders, and employers as well. And for spring, we actually have a 20% off discount, which is nice to offer that. And also in preparation for Mental Health Week, which is coming up, we've also offering 20% off of our mental health first aid kits, which are a great way just to really start the conversation, start to normalize it, and to put the H back into OH&S. All right, so that's enough with announcements, except for one other. I just wanted to let you know that I know that you're going to be excited and moved by some of the content that Jeff has to share with us today. And as I mentioned before, we're really excited to be partnering with him and working with him on facilitating and offering some workshops in May, May 10th to 13th, June 21st to 22nd, and on July 9th on this very topic. We're focusing in on supporting first responders, and the topic is around trauma and resilience. And so we're going to be some of the learning outcomes for these full day workshops that are made available by the government of Alberta is to be able to, of course, identify, a normal post-critical incident stress reactions and some self-care strategies, promote some more awareness of the critical impact and the cumulative impact of critical incident stress, and encourage people to get connected to support, and obviously to network as well, and just create that real connection with groups. And so we're excited to be partnering with a variety of different organizations to make these available. So stay tuned. We will be sending an email out after today's webinar, just so you have more information on those. And so without further ado, I'm really excited to start talking about the topic and to have Jeff with us. So just a little bit about Jeffrey Cartwright. So he has over 30 years experience working as a paramedic and a firefighter, a trauma clinician, and a mental health support and education. He's really passionate advocate for mental health and strong leadership and having psychologically safe workplaces as well. So he's, like I said before, he's worked in ambulance, fire, rescue services, including being a lieutenant and captain and acting battalion chief. And he's also a training officer and instructor at the Justice Institute of BC, British Columbia Fire Academy. And he's also a trauma instructor for the JIBC Center for Counseling and Community Safety, and a facilitator and trauma clinician for a lot of corporate organizations, and provides a lot of crisis management, education, and consultation to different workplace health divisions as well. And so, aside from obviously facilitating a variety of different workplace mental health initiatives and leadership training, he also provides a lot of crisis management interventions as well around trauma in the workplace. And he's a recognized TED Talk speaker, and he's also a partner with Wellness Works Canada. So really thrilled to have you here, Jeff, today to be talking about trauma and mental health. So I'll just pass it on to you now to take it over. So thanks and welcome again.
Thanks, Victoria. Welcome, everybody. Good evening, good morning, good afternoon. I know we have people from all over, so welcome. So today we have a short time together today, and we're going to cover some important stuff. But We're all zoomed out, we're all PowerPointed out. So I just want you to sit back and relax and kind of think about the reason why we do what we do. Today's more of it's a group of like-minded kind of individuals, compassionate colleagues, reminding ourselves why we do what we do, and just kind of getting to the nuts and bolts of trauma. So, and I also want to mention, we all bring our past with us to this course, and we are going to discuss trauma. So if it does bring back some painful memories, we're all friends here today. It's a safe place. If you feel triggered when we're talking, please reach out for help. But most of all, I thank you all for being here, because it shows your commitment to mental health in the workplace and taking care of people. So my approach has always been, when I work with organizations, is enough with the 1-800 numbers on the wall and having access to trauma handouts or trauma stuff on a website. We need boots on the ground. We need to acknowledge that we are in a bit of a crisis, and we do have some great ways to support people and to deal with things. We know, especially with first responders, military, who I deal a lot with, mental health is a struggle right now. There is a decline in mental health and first responders. We have a suicide epidemic. And that's not to even mention the breakdown of marriages or relationships with your children, with your families, and happiness. And one of the things is we're always talking about how to get out of depression or how to battle with high levels of anxiety, and we don't spend enough time saying, are you truly happy? And that's what's important. So I will, for reference, much of what the context of what I'm talking about is from a first responder point of view. But, I remember many years ago, I was sent to do a diffusing and crisis management training for the library system up in the Okanagan. And I was on the plane and I was reading through, the material I was going to be teaching, and I'm thinking, this isn't going to hit. They're not going to understand what I'm talking about. This is the stuff I talk to police about and fire. And, there's about 30 people in our group, and, just going around the room and saying, why are you here? What are you hoping to get out of it? And I quickly came to realize that library system they're first responders in many aspects. They're dealing with mental health. Every single person in that room, we were going around and immediately there was tears. And everybody in that room had either been assaulted, been close to being assaulted. Some had watched brutal assaults, dealing with mental health issues, dealing with overdoses and death. So, I'm talking about, we always talk about diffusings, debriefings from a first responder point of view, but, security guards, social services, even into high traffic Starbucks, the baristas sometimes are first responders. They're dealing with these things. So, and to kind of give you a quick insight, we tend to get into a camp, right, which is a clinical camp or a peer support camp, or a avoidance, is up to the individual camp. And back many years ago, I was speaking at a conference in Saskatchewan for the EMTs, and they have a conference there. And so I spoke at the conference, and generally I like to make my material applicable to the organization I'm talking about. So I did some research to try and find a real EMS study, and I found one called Reviving Responders in 2015. And it was a fascinating study. And so just a little insight, they basically had three major objectives with this. They decided they were going to do a survey monkey, and they were going to send it out to, it done down the US, and they were going to send it out to 6 states: Kansas, Missouri, Texas, Oregon, Colorado, and California. And they were hoping to get 100 replies. They knew with 100 replies, they'd be able to put some data together, but they knew more like with 500 replies that it would, they'd have some more accurate data, and it would be taken a lot more serious. Well, they sent it out hoping, and fingers crossed, hope we get 100 replies. Within the first hour, they got 1,000. And it quickly grew, and they cut it off for just, over 4,000 replies. And so there's three things that they wanted to identify. And first was the prevalence and severity of critical incident stress, including suicidal contemplation and suicide attempts in frontline emergency medical personnel. The second thing that they wanted to, the objective they wanted to look at is measure the effectiveness of current formal support. So things like peer support, critical incident stress management team, professional therapy, EAP, employee assistance programs, or private therapy. And then the third thing they wanted to look at is EMS culture as a whole, as it pertains to a field provider supporting mental wellness. So is the, sorry, too much coffee. So is the workplace supportive? Is the leadership and the management supportive? We have this problem, and it's one of the things that's really a pet peeve of mine, which is checkmark training. You've had the training, so now it's up to you, and we don't make sure that it hits home. So, they sent this survey out, and of the participants, and I try and think of these numbers, 85% of the respondents said that they had experienced the signs and symptoms of critical incident stress, and we'll cover a little bit of that. 37% had contemplated suicide. 37%. Now, if you take the CDC had done a report of the general population in the U.S., and out of their results, there was 3.7% of the general population had contemplated. 3.7% of the general, 37% of the EMS responders. Of the CDC's report, those that had actually attempted suicide, 0.5. Of the first responders, almost 7% had actually attempted. So again, one of the issues we get into is these camps, right? Like especially over the years with the critical incident debriefing model, we have a period of time where it's, everyone's on top of it, and we're looking at it and we're implementing it. And then something will come out and we say, no, the best thing we could do is not talk about it. And, going back to the Vietnam War, we know that more soldiers actually completed suicide than were killed in battle. So we know not talking about it doesn't work. But, the issues they kind of addressed were all the different areas, all the different camps, the, counselors that did not understand the nature of the work, or understand the culture of or actually just were poor at supporting that sort of that industry. They looked at peer support where they were not adequately trained. There was personality conflicts. The trust was broken. And that's a big one, with peer support or a critical incident stress team within organization. The second trust is broken, disband that team and start from, figure a new way and start from scratch, because when the trust is broken, you have to rebuild. And then, the other end was the leadership. Sometimes leadership says, of course we support that, but it's mere words. They don't support it. There's fear of judgment. Am I going to be passed over for a promotion in the future, or the negative work environment? It's a toxic work environment. This isn't the trust that I have. So, that's a brief kind of overview of that study. And it really, when I talk about similar, studies like that, you can see the people in the room nodding their head, because we've all experienced it. So what I started doing is, I've been part of lots of the teams, but I found more that when I became the clinician that was sought after by teams to go in and support the team, I always encourage them to take the lead, and I'll just be a supporting role unless you want me to take the lead. But my approach has always been, I call it the shoes off, a practical and spiritual approach. Is, first of all, I'm a self-admitted germaphobe. Long before COVID, I'm a hand washer, don't touch door handles, and never wear shoes in the house. But we have, taking your shoes off when you come to somebody's house, there's kind of two parts to it. The first one is obviously the sanitary, and then that sign of respect for the person's home you're going into. But the second one is much deeper, and there is a symbolic kind of thesis to it, which is that we're leaving the world behind. It lets our mind, our body, and our spirit know that we're transitioning from that outside world into the sanctuary of our own home. And this is essential with the key of, it's essential, like when we're supporting individuals following a crisis, we have to meet them where they're at emotionally. And then from there, we can determine where we're going to meet them at cognitively. So, you think about that when somebody comes in with their shoes on and sits down with you, you know they're ready to go. And when they come in, they take their shoes off and they sit with you. We know they're there for the duration because they care. And I'm not saying that when you go to a work site to do a debriefing, take your shoes off, but you get the kind of the implication behind it. So as clinicians and crisis responders, we need to have a toolbox full of skills, resources, and support. The biggest thing is you got to leave your ego at the door with your shoes. If you don't find humility, humility will find you. I often, a lot of the people that I train, they are clinicians already, and dealing with a crisis is a whole new ball game, and they're concerned with saying the wrong thing or possibly, allowing emotions or behaviors to go. And I tell them, if you think that every intervention or crisis that you're going to deal with is going to go smoothly, you're going to find out quickly that they just don't go that way. But what we can do, and this is crucial, is show up with empathy, with kindness, with strong listening skills. We can establish trust, and we can be consistent in what we say and what we do. And so generally with especially with the certification program at the Justice Institute, one of the things I really try to establish is you can have all the skills. You can have a wall full of degrees and education. But you think about when somebody's going through the worst day of their life, somebody's just experienced a multiple casualty shooting or a horrific accident, and you look them quickly and say, who do you want here? They want their sister or their brother or their mom or their partner. That's who they want. Even they know they might get glib advice or not good advice or no help at all, but they just need that emotional support. So as a clinician, we take our skills that we've established and our know-how and our understanding of that, and then we have to adapt. We have to be able to be what that person needs at that time. So it's really important. You check your ego at the door. If they're saying things you don't agree with, you don't like, that's neither here nor there. We're there to support them. So when we look at critical incident stress, we always talk about stress. We talk about acute or contextual stress, which is, that very intense but short-lived stress. And then we talk about chronic stress, that, it's not very intense, but it endures for days, weeks, months, and really can be toxic for our system. And we kind of classify when we look at with the DSM-5, when we look at injuries, as far as traumatic injuries, we kind of liken those into a capital T trauma or a lowercase t trauma. But critical incident stress, especially within first responders, and remember, I'm going to be talking about it in that context, it's something that we really have to take a look at because it is completely different. So I've sent Victoria a video, and she's going to play it right now. It's about 7 minutes long. It's short. It is a bit emotionally kind of draining, but if so, I hope you enjoyed it, and we'll discuss afterwards.
I think I've been to the murders of at least 8 kids that I can think of off the top of my head, and those are some of the hardest ones.
Patience is gone. You can't eat, you can't sleep. Every part of your life is disrupted.
It was tough. They reminded me of my friend's kids, and I couldn't get the screams out of my head for months. Our bad day and the average bad day are 2 different things. Our bad day usually involves something horrendous, carnage, and usually there's a lot of blood and death.
I got a call for a VSA infant, and the child was 1.5, 2 years old. And the circumstances were, it was odd when we got there, and there's a little girl lying on the ground, and her mom's bawling and freaking out on the phone doing CPR, and the kid was blue. And the dad standing like, I don't know what's happening, it's over there. I remember I was driving home from shift, and I got a call from the platoon chief from the other shift saying, oh yeah, by the way, that the dad snapped her neck and murdered her. You need to write a witness statement.
After 2 weeks of smelling rotting corpses in the Philippines after Hurricane Yolanda. We were on a road going to deliver an inflatable hospital up to the different region. And as we're driving down the road, a dog came out of the woods with a small child's arm in its mouth that it had found off of a corpse that's been there for a month, and that was its food.
We got on scene, and it turned out this kid had been cross-checked head first into the boards, had been unconscious. And we get there, and he'd been removed from the ice. When I'm talking to this kid, I'm kneeling beside him, looking in his face. He tells me he could feel everything till they moved him. Sorry, you seen that kid's face?
Just about every facet of everyday life changes. And then the biggest thing to me is the loss of innocence. You realize that these things happen in the world and they're happening all around you all of the time.
I felt like I was really armed to fight fires, to go to medicals, to do all these things, but they didn't arm me with something that I didn't realize was going to affect me so much, was dealing with the human nature of the calls and your own emotions and how to react to these things.
Us, police, EMS, we try and be the tough guys and tough people. And we are affected by this. It does have a cumulative effect, and it's not just one call. It's one call piled on the next call, piled on the next call, and it's like a house of cards. And you try and put that last card on the top and everything comes down.
You're going to experience things that you would wish and hope that you never experienced. You're going to see things that you can't reverse, that are going to be ingrained on who you are.
Lost myself into keeping busy, became very much a workaholic. Spent all my time just being busy so I wouldn't have to think about things.
I had a lot of guys that I worked with who'd been through similar things, and we used to get drunk all the time. You just hung out with people who were equally as damaged as you, so you felt normal. And there was some comfort in that.
So there was the black humor around the fire hall. People would joke about things, and that happens to this day.
I learned really quickly, though, to just kind of shut it all out and shut off your emotional response to anything, and that transferred into my personal life.
I didn't want to be anywhere near anybody. Even my own family, I just kind of pulled back a lot.
I know that there were times that I have come home from events that my children knew I was coming home from, that they stayed at a distance from me because they didn't know either what to say, what to do, or if I was going to snap, so to speak, and not be myself.
It's stuff that we take for granted day in, day out, that you see over the course of your career and what you do, that it's taken away from other people.
And what you realize is you're responding to the worst event of their lives, but you're responding after the incident already took place. And there's nothing you could have done by the time you've reacted and been called to this call to change the outcome. You can just do the best that you can do while you're there.
I know I've talked to people and said, listen, like I went to this counselor and it changed my life, and I wish I went to her the first day I had a bad call, and my life wouldn't have been as painful as it had to have been.
We're a team. Everything we do, when we go out that door, we do as a team. There's no one individual that can do this job, any part of it, on their own. We do this together, and we need to hold on to that when we come back to the hall.
You need to find that network of people that you can count on, that you can trust, that will be there for you no matter what. And those are the people that you keep closest to you throughout your career and throughout your life.
Found you in the trash, huddled in a corner.
Thanks, Victoria. So, you can see, and even at the end, he said, you need a network of people that you can trust, and that's that's our role as clinicians. I get the buy-in because I've walked the walk, but some of the best people that have supported me have no idea what it's like, and but they're there for you and they listen. And I can tell you, like, for those of you that have seen my TED Talk, I originally was asked to do a talk about trauma, and then quickly the person organizing it had said, no, I want to hear your story, because I told her my story, and she says, that's what you have to talk about. And one of the things to touch on is, they give us a uniform, and I'm wearing a uniform at 21 years old, and you see me in the street, you think, well, that guy knows what he's doing, and that guy, he's, nothing bothers him. But I'm still a 21-year-old kid starting off, and you're going to fires and seeing people screaming and dealing with the things you deal with. You don't know how to cope. A uniform is just that. It's uniformity. It's identification that you're part of that, but it's not a shield. And it's funny because and we're never static. I've done CPR hundreds, if not thousands of times, on elderly people. Well, when you're younger, you don't really think much about it. It's just another day at work. But as your parents become elderly, or your grandparents become elderly, or you work on a child, going to calls for children, never easy. But as soon as you start having children, it changes everything. And I remember I was actually telling Victoria this story. I got a call on Valentine's Day from an old lieutenant of mine. And he says, Happy Valentine's Day. He goes, I'm calling. And I said, no. He says, and I talked to him for a while. We're both retired. He says, the one time in my 30-year career I cried? He says, do you remember that Valentine's Day where in the morning we went to a SIDS death? It was just him and I on a rescue unit. He says, in the morning we went to his SIDS death, and you worked on that baby. And then in the afternoon, you delivered that baby on the couch. And I know I've been to lots of SIDS death, and I delivered 5 babies at people's homes, but I couldn't put 2 and 2 together. And he says, we came back and you were bouncing around like you always did. And he says, I stuck my head in the cabinet and I cried. He says, it was that circle of life. He goes, it's the one time. And he goes, every Valentine's Day, I think about that. And, I've said, I have 5 kids, and all my kids are going to have rib injuries because the amount of times I stood over their crib watching to make sure they took a breath. And for those of you that are first responders in here, you know what I'm talking about. And they don't breathe quick enough, so I poke them, and they take a quick breath and look at me like, what are you doing? And you tell that story in a group of veteran first responders, and they tear up because they know what I'm talking about. So this is the thing, and these add up. And maybe it's because I'm a grumpy old man now, but I look at some of the young recruits coming into the academy, and there's times when I talk about CIS, and I think, do you realize what you're signing up for? Do you know what you're getting yourself into? And that's where I don't think still to this day we're doing enough education to, we're recruiting, but we have to teach people, like, you're signing up for something that you don't really know what you're signing up for. So anyways, you can see that critical incidents is a critical incident stress. It's different from your your contextual acute or your chronic. It's what critical incident stress. It's a situation it's faced by somebody that causes them to experience unusually strong emotional reactions, and those unusually strong reactions have the potential to interfere with the ability to function, either at the scene, which generally we're pretty good at compartmentalizing that, but later on. And so what do? We have plans in place. We have peer support teams. Most organizations will have operational guidelines or operational procedures that will lay out, certain calls where we activate a support system. So maybe line of duty deaths, or death of a child, or incidents involving multiple tragedies, and then high media events, because those are tough. But what about the ones that we don't think about? And or it does, and this is where I say leaders have to lead, because oftentimes it falls on that leader to make that judgment call. When I'm training the up and coming lieutenants and captains and chiefs, I tell them, we know as an officer, our job was to make sure everybody went home to their families. And we always say that, but your job is to be constantly looking out to make sure that your crew is okay. And, and a good example, many years ago, I was working as a battalion chief, and I was coming in for my regular shift, and somebody said, "Oh, hey chief, are you here to do a debriefing?" And I said, "What happened?" And they said, "Oh, we had a SIDS death today." And I said, "Okay." And so I went into my office to relieve the other battalion chief, and I closed the door, and he goes, "I know what you're going to say." He says, "Before you say anything, I checked with everybody, and they're all fine." And, what do you say, right? And, like you said in my TED talk, fine's not a feeling. You can be hungry, horny, or happy, but fine is not a feeling. We as clinicians and as support, we have to dig deeper and get something out of it. I'm not saying push them, but we're not taking fine for an answer. So if you look at getting to the nature of first responders, why are we so vulnerable to critical incident stress? Well, if you look at, the majority of we're that type A personality, we're action oriented, we expect success, we like to control the situations, and we also need to have the ability to control ourselves. But if you look at the characteristics of the emergencies we go to, they're the complete opposite of our personality traits. So we're action oriented, but these things we go to, the emergencies, they're impediments to action. We expect success. Sometimes it's unsavable. We don't always win. We like to control situations. We're going to chaos. The best we can do at a large scene is control the chaos. And we need to control ourselves. Well, sometimes the situation becomes personalized. And here is where, as a clinician, for those of you that are clinicians, when there's key things that this is different from getting into therapy, which is you say to a firefighter who couldn't reach somebody, heard them screaming and couldn't get to them as the fire burned, and then the screaming stopped and they had to pull out, and you sit down with them and you go, "Hey, you did the best you could." That's a huge trigger for us. What do you mean I did the best I could? I failed. And so little things like that. I mean, you can come back from it, but having an understanding that we're not there to rescue the first responder or the person we're talking to, a clinician, there to support them and to allow them to foster their own resiliency. So, if we look at like a typical situation, it kind of goes like the accelerator brake analogy, right? So normally, we're faced with a physical or psychological danger. Our nervous system or our sympathetic branch will kick into that fight, flight, or freeze. And that's sort of our accelerator. It's our body's an amazing thing, right? We go into shock to allow us to walk when we shouldn't, or to get out of danger. And we have our fight, flight, or freeze, which increases the blood flow and the heart rate, and gives us the strength in our legs and arms to do what we need to do, while shutting down things like digestion and saliva production. So the body's amazing that way. And then when the threat's over, our parasympathetic system should kick back in, bring us back to that homeostasis or that natural balance, and that's the brake. But in some cases, in these traumatic experiences, it overwhelms our ability to return to that balance. So it's like having the foot on the gas and the brake at the same time. And this results in that individual struggling with, physical or emotional or behavioral and cognitive stress reactions. So when we have a crisis response, our goal is to stabilize that highly activated nervous system by balancing the trauma-oriented sensations that they're feeling with the individual's own resiliency skills. We try to connect them with their own internal and external resources by really making them aware of their strength and their resilience. And that doesn't mean the glib advice, like, come on, you can do this and you're going to get through this. A lot of it, gets into the motivational interviewing and good techniques. We want to assist them to experience those qualities that they're feeling in their own body and participate in that moment. We want them there fully, because then when they're in these highly aroused states, they can become sort of, especially in a group environment, and they see that kind of normalcy of it. But if we don't allow for that, they can become disconnected from their own capacities. So essentially what we're trying to do is we're trying to restore that well-being by supporting their own nervous system's return to balance. So we know following a critical incident, we have the kind of reactions. We have the acute reaction, maybe the 1,000-yard stare, or that inability to cope, or the crying. We could have the delayed, which are the ones that's why we're here today, is to be aware of these sorts of things. And then there's the secondary, right? The harming our, possibly compassion fatigue or vicarious trauma, harming other people inadvertently by talking about what we're doing. But eventually there is those cumulative reactions, like you heard in that video, where it's over time and, a long period of time. So oftentimes when, you are called to help following an incident, it's really important to look at that cognitive distress, because, following an incident, that's generally one of the areas that's very impaired. And so, people that when you're first put in front of them, they're still in that emotional state, and the cognitive function is really kind of off the map for a while. And so like a good example is one of the things I like to do if I can tell someone's in a real emotional state, and I'm, doing some one-on-one with them. Just little things like I'll just have two chairs and I'll say, would you rather sit there with your back to the wall, or would you rather look out the window? And they'll say, oh, I don't care. And I say, well, whichever one you prefer. It's nice looking out the window, but if you prefer to sit there, and they have to pick one, they have to say, well, I'd rather look out the window. So, we kind of snap them into that cognitive state where they've made the decision. And now, we have a little bit of chance to kind of to talk. And so, when they are in that state of that cognitive distress, there is that sensory distortion. There's the inability to concentrate. It's really difficult to make decisions, and they will start rolling the tape on guilt that they feel, or preoccupation with the event, and there is confusion. So that's where we have to, like I talked about at the beginning, it can't be all or nothing. It can't be we're going to give immediate support and the rest of it's up to them. We have to have a toolbox full of immediate support, good EAP programs, good therapy, and good, all the way along, and then follow up with those sort of things. So if we don't support, following the event, there are implications many times. So, at the time of our intervention, and also following, right? So the person may not be able to articulate what's happening to them. They might have problems, problem solving even, they could be impacted with stuff like that. Oftentimes you could say to them, well, what's your phone number? And they go, you know what, I don't know. And I've had the same phone number for 20 years because, numbers is one of the first thing to go. But, if we leave it untouched, there is that perception of, the risk of the relationship with their health leaving that area, right? So we know that there's use of drugs or alcohol, breakdown in relationships, and one of the ones that's so common is that withdrawal from normal activities. And that's what I kind of talked about in my TED talk. I said, as my rank started to go up, when I'm going from lieutenant to captain battalion chief, the whole time my mental health's going down, down, down. So our goal of that critical incident response is, number one, it's always don't make things worse. So we don't want to go on, we do not want to pour fire on the gasoline. So we don't want to make things worse. We want to help to manage their reactions. We want to normalize the situation. We want to foster the resilience. We want to give them choices, and we want to promote their recovery. So when we do that, and what, getting into, I don't like to get too much in the stats, and I did with the study with EMS study, but, one of the things I see so much now is, as soon as somebody deals with something bad, they throw their hands up and go, great, I've got PTSD. And I'll just say, well, so, what leads you to that conclusion? How so? And they say, well, I Googled it, and there's a thing called the DSM-5, and I meet all the criteria in all the different areas. Well, if we look at acute stress disorder, there's a very, very similar line between acute stress disorder and post-traumatic stress disorder. And, we all generally, after following a really traumatic event, are going to exhibit some signs of acute stress disorder. So generally around, 85 to 95% of people experiencing something very traumatic like that will experience critical incident stress reactions within the first 24 hours of the incident. And that's why, our difference from a diffusing, which is what we try to do as quickly as possible, away from the incident and safely, is much different than an actual formal diffusing or debriefing where we bring in a clinician. And so generally when I get called to do it, I'll say, hey, did you do a diffusing? Yes. Well, when did you do it? Today. And we want you to come in today. And I said, well, no, we want that 24 to 72 hour gap before we actually get into a more formal process for a debriefing, because that allows people that time to get some sleep, to see where their appetite's at, to discuss it with friends, to see what the tape that's playing in their heads. So when we do get together, and one of the first parts of, like using the Mitchell model, one of the first things that we do, which is not always applicable, is to try to get that full story, because that's oftentimes what's missing for individuals who are there. So when they come in, and so if we look at acute stress disorder going into post-traumatic stress disorder, if I talk to, Victoria following a bad incident the next day, chances are she's going to hit a lot of the criteria in the DSM. And, I didn't sleep a wink last night. I couldn't eat. I cried all night. It keeps playing in my head. And every time a door slams, I'm very agitated. And if I talk to her a week from now, she's going to say, whether she's even without support oftentimes, but especially with good support, she says, well, I'm sleeping again, but, I do think about it quite often. I'm still pretty, vigilant and I find myself kind of thinking about it, but I'm eating again. And then if I talk to her 30 days from now, she's going to say, well, yeah, of course it's still in my head, but I feel like I'm doing better. And so that's the process we're looking for. We don't want to just throw our hands up in the air and say, well, you've got PTSD, you've been to a bad event. Just like I said that, we have the ability to go into shock. We have the flight or freeze. We have the ability, we're very resilient human beings, and we do have the ability to heal, especially with good support. So back to those stats, 85 to 95% of the individuals will experience those signs and symptoms of critical incident stress immediately following within the first 24 hours. 40%, it's starting to go down within 3 to 4 days. If unmanaged, about 22% may have them for 6 months to a year. But generally the statistics, on the high end, they say 10%, but generally you'll hear around 4 or 5% out of some really traumatic incident will develop PTSD, and even then we can step in. So what are the key concepts that we have? We have key concepts to crisis support. So we do things like diffusings, debriefings, one-on-ones, walk and talks, and kind of going with that safer model, right? We want to stabilize the person. We want to acknowledge the incident, the event, and their emotions. We want to facilitate understanding and normalizing of the event. We want to encourage them. And then, facilitate recovery or referral if it needs to go further. So you have to remember that, it all starts with, and without getting too into the, my background is I'm very passionate about Eastern philosophy and breathing and mindfulness and proper, understanding that mind, body are connected. But we do know that the mind body are inseparable, and healing must occur in both. And it starts with our body, getting our body under control. And that's oftentimes what a diffusing in a peer support system will allow. It allows us to bring the body back so that the mind can follow. So we need a strong skill set as clinicians to be able to reduce the symptoms of the traumatic stress and allow that autonomic nervous system to kind of to lower down, to be able to process what's going on. And because the mind body are interdependent, if we can kind of start to stabilize the body by giving them that safe environment, the mind can possibly start to bring new meaning to that traumatic experience. And the results in sensations, it allows them to stay calm and feel that safety and hope for and that's all anchored in that safe environment. And I mentioned earlier that we don't rescue them. We don't say you did the best you could or it's not your fault. But very often times what happens in a great peer support environment is they rescue each other. And, that's one of the things that I always teach my clinicians is if you go into a debriefing and you run a formal process debriefing in a group, and you feel like you leave and you say, geez, I feel like that I didn't say that much. That's perfect. You should basically just be like a maestro and allowing them, the best ones that you do is they're talking it out, they're rescuing each other, they're filling in the gaps and really actively talking about their emotions and how they're feeling. So we have to keep in mind that the mind and the body, it does have that natural inherency to kind of heal itself. And all we want to do is build that resilience in them. We want to build it in the physical aspect, in the psychological aspect, the social aspect, and then the intellectual. So we want to really focus. And remember, we assume that everybody has emotional agility, and some people it's just not a strong skill. And to build good healthy agility within the people in our workplace, that emotional agility, it kind of falls along the line of that mindfulness. And mindfulness now, it's got such it's such a mainstream. Everybody talks mindfulness is this, and mindfulness is that, and mindfulness is a powerful, amazing thing. But we need to understand more that if you ask most people what is mindfulness, they think of this holistic sitting with your legs crossed and chanting, and that is not what mindfulness is. That you're getting into meditation. Mindfulness is truly being aware, curious, and learning to accept, and not just in traumatic situations, in everything. So that's why emotional agility is it's sort of has that Buddhism foundation, and it's rich in mindfulness, but it's us drawing awareness, noticing and identifying the emotions, the things that we're feeling, our internal thoughts, our feelings, the things that are going on with our body, and being present now, not focused on, where's this going to take me, or what could I have done different? It's being present now. And then once you're there, being curious, allow yourself to experience those emotions without judgment. Allow the critical thoughts, the ones that you want to force away, allow them to just kind of cascade through you and allow them to cause you that distress, because we have to deal with it now. And then once we start to get to, we allow it to go on, it's to have some acceptance, which is, embracing the present moment and the good and the bad. It's not a matter of giving yourself a pep talk. It's about saying, where am I? Simply acknowledging our feelings and knowing that they will pass. And it's really important that, so in a nutshell, that is kind of what mindfulness is. And it's a huge part of my life. And it was something that was missing for a long time when the job took a toll on me. And, there's days that I'll come home and I have no reason to be sad, but I feel sad, and I sit down and I go, I feel sad. Why do I can even laugh and go, why do I feel sad? I can't think of a reason. And I'm curious about it. And then I find there's a reason why I feel sad. It might not even be a valid reason, but aha, that's why I feel bad. So, and if you think of it more from a, applicable thing is, you can stub your toe at 7 o'clock in the morning, and, you stub your toe. We have that instant, we have that lapse, that refractory 1,000, there's the pain and it hurts. And we're angry at the stupid bed that shouldn't have been there. And then we, within 2-3 minutes, the pain subsided and we go to work and we're in a bad mood and we're angry all day long. But we have the best day at work. We have the best day with our friends, with our family, with our loved ones. And we come home and we're still angry. And if we didn't take that time, at our lunch break and go, wait a minute, I got to sit down. Why am I so angry right now? And be curious about it and go, my goodness, I have been angry all day. And it's about when I stubbed my toe at 7 o'clock this morning. So, it's really important that we understand that, we are human beings, and there's there's no model or approach that is going to work every time. It's about us being there and having this toolbox. And for those of you that I don't know if anybody knows me here, but I'm always willing to share and to, I like to give back, because you give back the more you give. And I'll never be territorial about this is what works or this doesn't work. So you know what works? Trying the things that work. And sometimes we got to pull out all the stops. And the other thing too, and just kind of, I'm going to allow some time. We're going to talk about as far as resiliency. I wanted to talk about that. You have to take control of your personal life. You want to be involved in tasks that you like. You want to make wise lifestyle choices. Have a good support network. Have a sense of humor. It's so important to have a sense of humor. Be concerned about others. We know that dopamine is not just attached to the reward, it's attached to the process. And we can get a dopamine oxytocin hit from hugging somebody or doing something kind for people. We need to actively be doing these sort of things in our lives. Be aware of suicide. It's difficult to talk about it in the workplace, but it's something that I really put a lot of focus in when I work with people is, identify those risks in your employees. If you're in charge of health and wellness for your employees, or you're a leader of an organization, identify risky behaviors, suicidal behavior, history, prior attempts, family history that they've discussed with you, any current or past psychiatric disorders, Axis 1, especially key symptoms, if they're losing interest in things, or their impulsivity or hopelessness, or giving away possessions. And ask the question. It doesn't matter. Before the COVID, I remember being at a convention, and I was taught hundreds of people this, and I asked that question: if you thought somebody was considering suicide, how many would ask them, hey, everything you're saying sounds like you're talking about taking your own life. Is that what you're saying to me? And let's say there was 400 people in the room, and like 7 put their hands up. And we do kind of have that idea that it's such an intrusive question, which it is, or that they're going to say, well, I wasn't thinking about it, but now that you put the idea in my head, thanks so much. But that's not the way it is. Ask the questions, inquire, ideation that they might have, frequency, how frequent is it, or what's the intensity of it? Do they have a plan, or is there a timing, a location, a lethality that they're planning? Do they have availability to that lethality? Is there preparatory acts? What is their intent? And then, if possible, to the best of your ability or training, explore ambivalence, the reasons to die versus the reasons to live. And that's where good motivational interviewing questions would come in. Do things like family nights, let families know, especially as first responders, that they need that education too, because a lot of times they have no idea. I've done many family nights, and they at the end of it, they say, I wish I would have got that 10 years ago, because now I know why he reacts or she reacts the way they do sometimes. Take care of people in retirement. That retirement can be a difficult emotional time for people. What kind of plans do they have? Understand that it's not a time to start new hobbies, and especially in paramilitary, like police, fire, and the military. Loss of rank is that loss of identity, and we want to address that, and we want to allow them the ability to have that support. So I wanted to leave you some time at the end here to ask any questions or share any stories or comments. I know Victoria won't be recording any of that, so.
Yeah, thank you so much, Jeff. Yeah, we'd like to absolutely open it up to any questions or comments that you would have. I just want to say there's so many great tips that you got out that you shared there, Jeff. Thank you. While we're just waiting for people just to formulate the questions there. I love the concept.
I blacked out, so.
It's all good. I love the analogy of a maestro when you're debriefing with somebody, and that's who you are, because that's everybody. Oftentimes we want to come up with the right questions or have the right answers, or we want to feel successful in a conversation, but that's not what it's about, right? It's about being that maestro and helping them get through that. And some really great tips here around just the emotional agility piece and the mindfulness piece. And I think that's really critical as well. So I think a couple of people had some questions. Can you, like Callie or Catherine or Hilda, if you just have questions, throw them up in here in the chat here. as well. So Dee had a question of who's an owner of an EMS company, if you can recommend a good sources to advance knowledge in this area to better support the team.
As far as putting together a peer support team, or oh, as for EMS, you know what? I'm not sure where you're located, but it's there's tons.
Alberta.
Alberta. Well, I'll be there, so
There
you
we
know,
go.
talk to Victoria and we'll line
Join
something.
us. Yeah, join us on May 10th to 13th, or June 21st, 22nd, or July 9th. Yeah, so we have some full day workshops on trauma and resilience, and Jeff's going to be speaking at those, and they are really an amazing opportunity, thanks to the government of Alberta, that will be available. So that'll be really great, and a supportive opportunity for you here as well.